So just by way of a brief introduction of myself, I currently lead IHI's portfolio of work in Africa as the executive director and head of the region. But beyond the work that I've done, there's also been very close support for my ISQua level activities. So currently I'm a member of ISQua. I also had the distinct privilege of undertaking the fellowship, which really drove the career path. And currently I serve as an assistant editor on the International Journal for Quality in Healthcare, and also got elected as a foundation member of the International Academy of Quality and Safety. So closely supporting ISQua to roll out the agenda in Africa, and I think that has been great. But today, more specifically, we wanted to focus a little bit on some of the global conversations as it relates to the efforts to improve the quality of care. And then also, as we said in the initial blurb sent around, reflect a little bit on the implementation framework that has emerged from some case studies that IHI as an organization conducted in 5 countries. We talked about Ethiopia, Mexico, Scotland, Ghana, and Mexico. And then what the framework is, hopefully we can, reflect on that. And then the last thing will be what the implications would be for whatever you're doing. We talked about big system quality, and we know that the levels would vary. For some people, it will be national health systems. For some, it will be large hospital systems with a number of smaller units. For some, it will be at the district level of management. And for others, it would just be one hospital unit with a number of departments and various units within those departments. So the big system really is flexibly applied, but I believe that some of the concepts and strategies will be equally applicable. Next slide, please. So by way of the session objectives, in 2018, you recall that the world saw a number of global reports, talking about the state of quality of care in the world. So hopefully we'd reflect on some of the recommendations emerging from there. And then we look at some of the frameworks used within those global reports, and then finally reflect on the case study and the framework that emerged from that, which would be a more practical look at how the national efforts to develop and implement quality strategies would have gone in some of these countries, and what the takeaways could be in your own work. We are hoping, next slide, please. We are hoping that I will pause somewhere midway for some early reactions, so you can chat in your comments, or you can unmute yourself if Katarina is managing that process, so that if there are any specific questions that you have, we could address them, or you may have some contributions from your own experience. I would be thrilled to learn from you as well. So now I just want to focus a little bit on the global framing of quality strategy and management, following from the 3 reports. And these 3 reports that came from 2018 really referred to by quite a number of people as the year of quality reports. One was the Delivering Quality Health Service, a global imperative for UHC. This really came from WHO, OECD, and the World Bank. Then there was also the High Quality Health Systems from the Lancet Global Commission, and then Crossing the Global Quality Chasm, that came from the National Academy of Sciences, Engineering, and Medicine in the US. And there were quite a number of points of alignment that I would reflect upon shortly. If we can go to the next slide, please. So you would remember that the National Academy itself did an initial publication trying to look at the state of quality. And a lot of these reports were coming 20 years after that. So with some of the highlights being the fact that the work that was looked at across 137 low middle income countries, and the fact that about 8.6 million of those deaths that we are recording in various healthcare systems across the world are arising from issues of access and quality. And of this, 60%, is due to poor quality of care. So just to give you a sense of the burden, And then when you look in the area of non-communicable diseases, the fact that as many as 4 million avoidable deaths were happening. And then even those who were not dying from these non-communicable conditions, you have over 830 million of them simply not having even their conditions being diagnosed. And there you would see the potential that high quality health systems have to address the situation, that those types of systems will save us so many deaths, whether it's from cardiovascular diseases, newborn deaths, tuberculosis, or maternal deaths. If you look at even the maternal deaths, poor quality of care contributing as much as 50% to the mortality, so that if we address the quality of care issues, we could immediately be looking at saving 50% of the maternal deaths as we see it. And then the economic cost, the last point really, 1.6 trillion USD, the sheer economic cost, and in some of the reports, they talked about waste, that in a number of these low middle income countries that were resource constrained, you came across instances where sometimes newly built facilities, well stocked with all kinds of state-of-the-art equipment, simply not being used, maybe from political conflicts and all kinds of things. So the economic impact tended to be very huge in a number of these places. And even some lost productivity days from some of these conditions that various people struggled from. So there's a huge economic impact from poor quality of care as well. So the next slide, please, then goes on to the framework that was essentially put out by the Lancet paper. And this, I think, follows the basic Donabedian model that is looking at the inputs, the processes, and the outcomes. But I would like to start from the outcome, by way of setting ambitious goals. Where do we want to go to? What is the desired end state? And if you look at the outcomes, I think the Lancet framed it more as quality impacts. And they looked at better health, so that from whatever experiences people had, they would be healthier. We would know what is wrong with them. They would get evidence-based treatment. They would go home better. The second one had to do with the confidence in the health system. This is a little bit more difficult to measure. How do you measure the confidence in the health system? And I recall that in the era of Ebola in Liberia, and maybe even to an extent during this COVID era, communities simply had no trust for what the health professionals were saying. And people would come to the communities to bury dead relatives, and the community would just rise up. Community members may not even want to come to the facilities. There's doubt as to whether COVID is a real condition or just something to control the population, So increasingly, the matter of the confidence that people have in the health systems comes to the fore often and often. And then I think I've said quite a little bit about the economic benefit. So by way of outcomes, there was this focus on what the Lancet paper described as quality impacts. So then the question becomes, what are the processes of care that we can focus on to be able to achieve those impacts? And that is where they talked about competent care and systems, and then the positive user experience. So is the treatment in line with the latest evidence base? Do we have what it takes to adhere to protocols? In reliability science, we'll talk about being able to provide evidence-based care over 90% of the time, all the time. So if we showed consistency in providing a certain quality to all the clients, then hopefully they would have a good experience, and that would lead to some of those impacts. The question sometimes arises as to how many people are consistently measuring the patient experience. In many of the systems in LMICs, they will talk about patient satisfaction surveys that will be done maybe on a quarterly basis, and all of the conversations around the patient's comfort in expressing their true sentiments. There are some hospitals that I've worked in that I know use Net Promoter Score. So to what extent are you going to recommend the services in this facility to your relatives or to other friends? So being very rigorous in tracking what the patient experience has been and then tackling them in a systematic way was also something that was highlighted. And by way of the inputs, that is where they propose a number of inputs grounded in equity, resilience, and efficiency. So what are the population needs coming into that health system? And what are their expectations? Then there was a whole section on governance. And I think today's session would do a little bit on the governance, where you tackle the policy, a lot of health financing mechanisms that are trying to tie even reimbursement to quality, ability to achieve quality gaps, and sometimes even some of the market-oriented approaches. So in some countries, there's discussion about pool procurement methods, so that we sort of constrain the system into addressing clearly identified quality gaps. And then clearly the issue about non-health sectors. In many countries, they will talk about outbreaks, meningitis, cholera, and so on and so forth. And yet you would find out that a lot of ministries of gender, of local government, of sanitation have quite a say in how these impact health. So certainly the need for intersectoral collaboration also comes to the fore. And then on the matter of platforms, how we reorganize care, the workforce, making sure that we have enough and the right kind, and then the various tools, to be able to diagnose the conditions, and availability of medicines that are affordable, and last but not the least, data. So the thinking being that if these things came together, not as separate inputs, but in an environment where we pay close attention to how they interact, learn from whatever gaps and successes there are, and then input them into those processes of care, then we would be able to achieve those quality impacts. Next slide, please. This really looked at a very high level. This is from the WHO paper, 5 strategies for people-centered services. And there are similar themes that run through. They talked about empowering and engaging people, strengthening governance, looking at the model of care, and then also coordinating the services. And at the center of it was the kind of environment that we would all want to enjoy when we are unwell. Next slide, please. So just to maybe spend a little bit more time on the governance issue as it came in the paper. So one was really the recommendation around adopting a system strategy, in that a lot of the time it's been that we come at it with different lenses. So HR people would say it's an HR problem, or some people would develop strategy documents on clinical guidelines and protocols and so on and so forth. System view simply meant looking at the outcomes that we were trying to achieve in various systems. How do we get all of these different parts to work together? The second bit has to do with learning from data. Traditionally, a lot of the facilities will talk about inability to respond to the data. And M&E experts will talk about the management question. So there are various questions at multiple levels of the health system. I think that the skill that is required is to be able to define the needs of a small quality improvement team in a maternity unit that would tell them about the effectiveness of the changes they are testing. And then the very high level outcome-oriented access type indicators that may be collected at the national level. And then also, as we talk about putting quality at the center of the UHC conversation, because we say that coverage without quality is meaningless, what are those type of metrics? And how can we build a system that we constantly learn from each other, learn from what is working, and move away from islands of excellence into large-scale improvement effort? And then the issue about support for managers. So there's a whole dynamism about this, that we may create a policy, we may prescribe actions at multiple levels, but then also supporting managers. So in a number of places, if you look at the facility manager, the district manager, regional manager, are they appointed because they've acquired clearly demonstrated skill sets, or have they been appointed because they have stayed longest in that position? And then supporting them to be able to achieve not just the clinical outcomes, but financial and management level expertise that will support the operations of the health system. And the last bit has to do with regulation. I think that the reports also embrace the fact that it's not just one approach. So continuous quality improvement is certainly important. Team-based approaches are important, but also the regulatory function, whether facilities are licensed, whether they are meeting basic minimum standards, the transparency around how we report so that citizens feel like they can be guaranteed a certain minimum of quality. And the idea was that, as Duran proposed, it is not just one side, but the quality planning, the quality control, and then the quality improvement aspects all need to come together as we govern for quality. Next slide, please. So this really was another recommendation that came, I think, from the Lancet paper talking about reorganizing services to maximize health outcomes. And the basic principle was whether the health systems are organized in such a way that patients get the support that they need at the level at which they need it, when they need it most for the conditions that they are looking at. So we have systems that say, perhaps you go to the community health centers for certain types of conditions. The reorganizing was to say that we should have a system that identifies danger signs very quickly and activates referral mechanisms so that patients can get to the level that matches the complexity of their diseases. So I recall that recently in some conversations in South Africa, there was the suggestion that perhaps they could even consider putting mobile maternity units in some of the secondary and tertiary centers, given that a number of these women were coming to these centers to deliver. So that if a normal, non-complicated delivery suddenly became complicated, there wouldn't be such a huge lift between moving them from where they are to the level of care that is required. And that's not to say that everybody should go and deliver at the hospital as one of the recommendations stated, but really to say that a lot of people now are beginning to think about models that actually work to be able to assure patients that they would get the level of expertise that matches their need. Next slide, please. Igniting demand for quality is really a matter of how we engage communities, populations, citizens, so that we stimulate demand at their level and they do not become passive consumers of the products of the health services, but really are engaged actively. This really has been interesting as I've gone around, spoken to people. Sometimes one senses some hesitation at the level of health professionals on how to really engage patients. Some of us are concerned that doing this, opening up and engaging them either as members of quality improvement teams or as members of patient and family advisory councils, or by moving along the path of data transparency and making our true performance known in an open manner. Sometimes the fear is that it's going to show up medical legal incidents and so on and so forth. But I think increasingly this is the path that is being promoted, that we work hand in hand with the patients to co-create the service process, and then we can work on the things together. So there are bits about reporting, community reporting, patient participatory groups. There's no one size fit all, and I know that different countries are trying different approaches. Recently, there's been talk about a community scorecard, for example, in Ghana. I know it was also tried at some point in Malawi. Idea being that the communities get together as some sort of a focus group and they provide feedback. And that feedback is sort of codified into the district health information management system so that you can look at what the community actually thinks about the quality of care. And together, they can work hand in hand with the health system to develop models that address those gaps. In some places, this has led to renovation of facilities, sometimes building of new CHIPS compounds, and all kinds of things. But really, it cannot be one-sided. To be able to drive the system to a new level of performance, patients do need to be more actively involved and to have a stronger say in how their care is planned. The next slide, please. So this is a point where I'd just like to pause and to say that in this initial part, what resonated with you and what contribution might you have? So I'll just pause briefly for that. You can either chat that in or you can unmute yourself and speak up. So we are waiting to hear from you if there are any comments, whether this resonates with some of the quality of care gaps that you are dealing with or not. It would be good to hear what you have to say, or if you have any questions before I go to the next round.
May I give a comment?
Yes, please.
Thank you, Dr. Sodzi, for the presentation. Let me remove the doctor. You said we should call you Sodzi. Yeah,
indeed,
thank you.
Indeed.
Thank you for the good presentation. My name is Lydia from Kenyatta National Hospital. Just to appreciate that indeed we are on the learning curve towards measuring the patient experience. And I think, as you mentioned, that various tools have been used. So previously, similar to your comments, we have done the patient customer satisfaction, which gives a percent that does not at times reflect what is really on the ground. So we are trying to follow up on patient experience, but I think this platform will enable us to hone our skills more so that we can get the aha moments and the moments that were really down for patients' experience through the system. So I think that is a measure that we need to make it compared to the rest of the other technically measured or waiting times and the other aspects of care that are to do with the structures. Yeah, thank you.
Thank you very much for that. I see a comment here about what if the data from the community is not real? And I mean, spot on. Sometimes we've worked in systems where the communities are so intimidated that the thought of even giving honest feedback is sometimes of an alien concept. And it requires some careful facilitation of that conversation so that there's psychological safety. And then also it builds a lot of confidence when the community sees that there's nothing punitive emerging from the feedback. It is done openly, and there's actually some action to address whatever feedback it is that they provide. But I know it's not that simple. I saw Elom made a point here about the challenge being lack of or the supposed understanding of managers, and being how we can work to make managers understand and to ensure that we are all on the same page when it comes to our understanding of quality and safety. Well, you are right. In some of my earlier work, we would go straight to the front line, work with them, get exciting results, only to realize that managers didn't really understand, or that they had different pressures. So you will go to the board and maybe 80% of the board level conversation is about financial metrics. So we do have a responsibility to gently facilitate the conversation to say that if quality and safety are in top shape, then it would ultimately affect the bottom line of these organizations. And then also to plan some training programs for the leadership. I think sometimes the challenge is that we expect managers to sit with us for 5 days, going through the courses that the improvement coaches are going through. And maybe not, they don't have the wherewithal to do that. So if it's 3 hours that you are going to have the manager in this COVID era, then how can you develop something that is just for 3 hours for them to just to orient them so that they can analyze? Another powerful tool is also to take them on site visits. So it's one thing in the boardroom or in your big office and postulate what is going on in the hospital. But if you go with a quality manager around and you see the real pressures that the health professionals are facing on a day-to-day basis, I think that also helps to shift a little bit. But support is absolutely key, and which is why sometimes it's good to get them to even formally commission these plans.
And Soji, I think Godswill is there. He's able to talk there now as well.
Wonderful.
Okay. Good afternoon, everyone. Good afternoon.
Hi, Godswill. We can hear you.
Good afternoon.
Okay.
Godswill.
Yeah. It's just a comment with respect to end users of healthcare services. I've observed that sometimes, in fact, most of the times, the end users, they don't even know what quality is. They don't even know what safety is. And because they are ignorant of the definition of quality, they tend to accept low quality care and services as normal. So whatever you do, they accept it. So my big concern is that how do we get our clients or end users to begin to understand the nature of quality and safety in with respect to healthcare. I think this is one of the challenges we face in our own setting here, because the people don't know. They don't know what quality is. So whatever you give them, they accept it. And if you want to take feedback from them, they are just telling you based on what they think is normal. So how do we get our clients to come up to speed with what we define as quality and safety of care? Thank you.
Thank you so much, Godswell. And I don't know whether there's a one size fit all. So I know that in some places, people have come up with what they describe as a patient and family advisory council. So this may be a group of community leaders who then are either integrated into their board or they meet separately to take some sort of community feedback. And then they can then make representation at the level of the board or senior management. And then the hospital also feeds back to them. And that kind of engagement sometimes clarifies what the expectations around quality tend to be. So then we sort of sharpen each other. Another strategy that I've seen people use is to open up the quality and safety teams to include community members. You know, so the QI team is made up of doctors and midwives and pharmacists, but it also includes the chief and the queen mother and the gender activist and the youth leader, you know. So that interaction sometimes tends to be very interesting. I had one that I observed on a referral project that we did. And the community members tended to be very vocal and opinionated. At least if we are starting off from the gaps in the system, then they would do a good job of telling us what the current status is, and then together we can find out what works. So somebody, Ayodeji, is trying to help me. He says that in response to that comment, patient education is key. Indeed, in many of the health systems, we have patient charters that are very eloquent in the elaboration on what it is that patients need to know, their rights and their responsibilities. But many places, these are just books, you know, that nobody is reading, you know. So those efforts to bring them to life, even simple things like putting your name tag on your uniform, so patient knows who specifically they're dealing with, all the efforts around explaining what the surgical procedure is about and getting informed consent and all of those things would just set the clear expectations around what needs to happen. But I agree that there's just a lot more that we all have to do. So maybe we can move on. There would be another time at the end to also reflect, but thank you for your discussions, for your contributions. Lots of learning for me as well. So Katarina, next slide, please. So with this sort of what you might consider the baseline, the status quo, how do we then go around building their quality strategies and quality management systems? So as I said, the clients have a great role in telling us what the current status is. So if they tell us that we have a net promoter score of 20%, that means if you look at your top referrals and you weigh it against those who would not recommend your services to others, only 20% on the average are actually going to recommend your hospital or your district health center or your country's health system to anybody else. And from there, the next slide, please, you can ask yourself what the vision is. Where are we trying to go? So let's say in terms of net promoter score or patient satisfaction, we want to shift it to 80% or 90%. Then the strategy becomes the how. What are the specific tangible actions we can take to drive the system to this new level of performance? Next slide, please. There we come to the matter of the quality management system. And just to say that a number of health systems do a great job of developing these quality strategies. or writing quality plans. The deployment then tends to be the challenge. And this is where the concept of a quality management system becomes helpful. What you tend to see in some countries, and I saw it in some Middle East countries and many other places, is that the idea of integration also tends to be missing. So you would have a unit, for example, that develops clinical guidelines. You may have some people that say their work is incident reporting, and some people who say they do training, but they don't have somebody at the national, subnational, facility and community levels looking consistently at metrics that tell us where the successes and the gaps are, and that show alignment between what people are doing at the front line and what the whole system of measures would show. So really, that is the ideal that we are looking for, that there's somebody, especially within management, together with frontline improvers, looking at the gaps and commissioning efforts that align to those gaps. And we can always come back and see what is working, identify those, blow them up in the system so we know that, look, there are successes happening in this county, and how can we rapidly learn and scale it up? So doing that in an integrated approach is really what helps. And when it comes to gaps, the gaps may come from those who are setting standards, the gaps may come from the patient feedback, gaps may come from the incident reports. There are many ways in which we can identify those gaps, but then we have this cyclical system where it's organic. People are, learning from each other, and the system is responding to the real needs on the ground. Next slide, please. So this is where some of the lessons also came from our initial work, where we worked within those 5 countries to tease out the lessons. And 4 key components that came out were the commitment phase. We thought that often for people to develop their strategies and to go through the implementation, there often tended to be a phase of commitment. And then once you have what some may describe as a critical mass, enough people saying the same things and expressing concerns about the same issues, they would then move into a development phase. And once it was developed, there will be some efforts to implement. And then in many places, there's the effort to move away from projectized activities. So how do you then integrate these into the normal functionality of the health systems? And how do you make it more sustainable? How do you define new gaps? And how do you form new improvement efforts around these new gaps? So the cycle never really ends. Is what we learn from this work. Next slide, please. So by way of the commitment phase, that's where we talk about courageous leadership. And I mean, this was really coming from some work in Nigeria, where a former health minister, I think there had been some adverse press reportage about bad interactions with the health system, bad patient experience. And he had literally stood up and said that, this really has to change. We need different stories. And in many places, we spoke to one hospital leader in South Africa who just showed us press clippings of all the bad things that have been said about her hospital. And she stood up and said that I need to just change this. Something needs to happen differently. So often we saw that there was this mark of courage in the leadership. And then there was the matter of even situational analysis. So how are the leaders relating? Are there priorities, concerns about the various priorities shared? Or are there some leaders who see certain gaps and others don't see those gaps? What are the data systems? In many places, there's the effort to improve. But then without data, you cannot really assess correctly the impact of the changes being, tested. And yet the data systems are flawed, in terms of completeness, timeliness of reporting, and accuracy. So what is the state of the data system that we have? What are the capacity level issues? This big vision that you're articulating, do people have enough expertise in the science of improvement to be able to take it forward and to drive it down at multiple levels? Because what you don't want is a document that is only known about and held in high esteem by some people at the high level. But the midwife at the maternity ward has no clue what all this quality strategy business is about, you know. So that kind of systematic situation analysis, working with a variety of stakeholders, including patient groups, will then help, you know, to be able to galvanize the force to develop it. Then there is the issue about national health priorities. So I don't know what your thinking is about this issue, but there are some people who say that there shouldn't be anything at all like a national quality strategy. There should just be a national health strategy, because the whole purpose of the health system is to deliver quality of care. So some take this approach because what they argue is that you may have a quality strategy that is not speaking to the health strategies articulated by either the ministries or the governments or the leadership. So the document is powerful. It speaks to a number of things, but you know, it's not connected. It's not mainstreamed enough, and it's seen as some side operation. You know, so always we found out it was very helpful when these quality-related goals were directly linked. And I recall that in Scotland, they had one goal around making Scotland the best place to develop as a child, you know, and they built a whole improvement approach around that, cutting across a lot of sectors and across a lot of agencies. So what you don't want is to have a lot of energy around the gaps and people wanting to do something about it, but then you develop a plan that is quite divorced from your day-to-day realities, and that makes it difficult for people to connect. Next slide, please. On the issue of the development, there we now have to pay attention to quite a number of things. What are the various structures that we can put in place? And sometimes this is where you come across all kinds of, I don't know, philosophical debates. Is it quality assurance team? Is it quality improvement team? All kinds of things. So in one instance, we ended up with quality management teams. And we thought that that should be able to embrace the quality planning function of the leaders and the managers, the quality assurance as it relates to using the data to be able to assess whether we are matching the gaps or not, you know, meeting those gaps and all the standards that have been set, and the quality improvement really focusing on the team-based approaches to change the level of performance. And then I've also spoken about the matter of the data systems. And on the data systems, I know that many places have the DHIS, you know, very robust data systems and all of that. The challenge has been how these quality governance structures can agree on a core set of metrics. I don't know, maybe 10, maybe 12, that when we say what is the quality and safety performance of your system, country, county, region, one hospital, that the leaders can speak to it and say that on safety, this is where we are, on equity, this is where we are, on patient experience, this is where we are, a few of them, you know. So I think at this point, really the conversation is to narrow down and focus on a few. And then I've talked about the quality methods. Accreditation is important. The capacity building is important. The market-based approach for financing, important. They are all important, and it's just a matter of how we coordinate them to make sure that the push and pull effect is leading to overall quality. Then the local definitions. I mean, everybody knows about dimensions of quality and all of that, but the country could actually look at its status and decide that for us, the fulcrum, everything is going to revolve around equity. And I know Ethiopia has been very tough on equity, the same standard of quality of care for every citizen, wherever they come. So you see that we're talking about 100 million people and you want a certain quality for all of them, very ambitious, but the local flavor is very important. And then the quality capacity. This vision is going to be driven by leaders at different levels. So being very systematic in training them. You train the board, you train the executive team, you train the improvement advisors leading various departments. I recall some interaction at Cincinnati Children's that I had some time back. Their plan was to train everybody. As long as you're working there, no matter who you are, you will go through the course and you will run an improvement project. So there was just such fantastic alignment, and it was great to see. And then the last bit is the finance strategies. These things do cost money. So making some allowance for that, whether it's some small budgetary allocation or whatever the arrangement is, it's good to make some arrangements so that it doesn't become a plan that is not supported by way of its implementation. Next slide. The matter of the implementation, I've not seen in many places where the strategies have a costed plan. But this is also where at the early phases, if we can link it directly to strategic health priorities that are already acknowledged by senior leadership and are being funded, then it is key. And what we saw in some countries was the effort to position the quality methods as a means to. So whatever the leadership priorities are, we said that if you are able to adopt these series of methods, it would help you to achieve. So demonstrating that clear value add tended to be very important. And then of course, the launch and the communication plan, so that at every level, there is clarity on what the expectation on the quality plan is, so that we are proactive instead of sometimes what you see when things go wrong and then suddenly everybody begins to run all over the place. The next bit is the learning systems and the culture. And I know somebody put in a chat there, Ayodeji, I think, about the culture. You know, sometimes, a lot of the time, a lot can go right if we can take away that punitive culture, the fear that if we make mistakes or if we report mistakes, I'm going to be blamed personally. And in some work that we did in safety, which we may be able to speak to at another time, there are tools, simple tools that help us to measure the culture of safety at multiple levels of the organization. And it's so powerful when we did it in one place. Then managers look at the feedback from the front line. When you are sick, will you seek care in this facility? Do you think that there's a clear plan to build your capacity as a healthcare worker? Do you feel comfortable talking about errors when they happen? The managers were shocked at the kind of feedback that came forth, but there was just such a congenial atmosphere for reflecting on this feedback and working together to be able to address this. So there are tools around that, you know, to be able to show that people can report on adverse events, and more importantly, we have a system using those structures to address them. Next slide, please. Then we come to the sustainability bit. So as far as implementation goes, we cannot tackle all the problems all at once. You know, so what you found a number of these countries doing was to go through systematic prioritization. So in the ideal situation, we have the status quo, we have our quality metrics, we've collected baseline, we know where we are performing well, where the gaps are, and then we carefully guide the selection of priority projects that are aligned from national to community level. And then we can systematically work our way through. We may get to the point where those indicators are no longer problem indicators. So we shift that continuous improvement process into some sort of a quality assurance process. So we now routinely measure. I know one facility where they've had a gross mortality ratio of less than 1% for like 5 years. You know, so it's a very stable process. But thanks to COVID, over the last 6 months, that is now hovering in the range of 3, 4, 5. But it was something, an indicator that we were just keeping an eye on. We were not actively doing anything to improve that. But because we're keeping an eye on it, now we know that mortalities really are shooting up. So that's really the kind of dynamic I'm talking about. And then also, you could really be able to select new projects to focus on. So again, in this particular facility that I'm talking about, the problem now became needle stick injuries. Nurses and doctors being pricked all the time. That became the new priority. But as we looked at the data, that became some area of focus for improvement. So then the question becomes, when the best lessons are learned, how we can systematically promote them across, and how we can adapt whatever the structure is to be able to respond to the needs. So it's not really static, and what new training needs are. So the conversation now is about how do you infuse some of these lessons into pre-service education so that you don't wait till people come out of school before you say you're going to train them. But as part of the education, these concepts around quality and safety are actually acknowledged. So these are generally at a very high level, some of the lessons that came out from that work. Next slide, please. Okay, so this really is an opportunity for reflection. There isn't that much of a slide. If we can go to the next one. If we had more time, of course, we will now do a breakout and go and develop our own quality plans for our systems. But I'll just pause here for your own reflections, whether you think that there are applicable strategies that you can test and implement in your own home organization. So I'll pause here, Katarina.
Great. And actually, as many of the people here will be fellows, I think this would be a really good exercise to use for your reflection. We are offering credits for the fellowship for attending this and also for submitting a reflection at the end. So perhaps we can use this, this question here as the basis for your reflection. Are there applicable strategies you can test and implement in your home organization? So it would be really great to hear from you about that. So if you want, we can have a look at some of the Q&A here. So Elam had said, I think the challenge more the lack of or the supposed understanding of managers. My concern is how can we work to make managers understand and to ensure that we are all on the same page when it comes to our understanding of quality and safety.
I mean, quality is a beautiful word. There's nobody I know of who would say that they don't want quality or safe systems. Mm. So sometimes it's used very nicely and you don't know specifically what it is that people are talking about. I think also that it's helpful to hold accountability at the highest level. So it's not Elom as a hospital manager trying to change the system overnight, but it is really concern that is shared at the level of the board. And sometimes that may come from showing them the data. So in some places that I've been supporting, we've been looking at the data, but one day we had a very powerful time when we brought a patient story to the clinical governance committee. And in the patient's own words, they talked about their experience and you could see the communication dimensions. You could see the matter about availability of essential drugs. You could see the disconnect at multiple levels of the health system. And that was just a very powerful way to get the managers to appreciate that quality is actually our business, what we are set up for. Yeah.
Great, thank you. And Ajabike, how do you calculate the ROI for quality, as there is often an initial investment to be made, and so we need to convince those who will make the decision that the investment is worthwhile? Yeah.
This return on investment is just such a critical question, because sometimes quality then comes off as a cost driver. So on our projects, on typical projects, we've looked at the long-term investment of the funders, and we've tried to do some cost effectiveness analysis. And specifically on a Ghana project that ran for 7 years, we thought that it was a cost-effective intervention. On the level of, let's say, hospitals, I think what I'd heard some of the more financially inclined board members argue is that whatever the initial investment is, it should be able to lead to more efficient systems. So the removal of waste. So where we are able to demonstrate that these processes that we are improving and streamlining and all of that rather increase the efficiency in the health system, reduce delay in waiting time, and in essence enables us to see more people, it will then affect the bottom line. But it is often challenging, because I know GPK has led quite a number of efforts to drive accreditation. And as you go through that process, you actually do see the huge investment that is required. And so it's often a difficult conversation. But I think it's good to put it front and center and to maybe do a better job of pushing people to look at the end goal, where we are heading, because it's a journey. It's not something that happens overnight, but that's often a tough conversation.
Ajipike, I don't know if I'm saying your name correctly at all. But she's asking if you're able to share the tools for measuring the safety culture at different levels.
Fortunately, I have her number, but I will send it to you. Then I think you can share it through the network.
Brilliant. That would be great. Thank you. I'm sure there's others interested in that as well. And I just checked the time. Okay, we have a few more minutes. There's a question here from Elam as well. How do you involve community participation in an environment that is very litigious? Healthcare are generally scared and don't know who to inform and how much information to give because of the lack or little trust in the environment. How can we create a trusting environment to make engagement possible? It's a good question.
Well, you are right. I think it's important to acknowledge where a number of health systems are coming from. You know, in a number of these LMICs, which maybe would be my focus for now, you are coming into systems where health workers and health professionals are seen to be all-knowing and all right. And so there's just such a huge power differential in the engagement between the clients and the communities and these people. So it's something that we would just have to work on. But beyond wanting to work at it, we have to build it into the plans. So if your plans want to make patients part of the conversation, that has got to happen. I mean, I've worked in places supporting governing boards where 80% of the conversation was dedicated to financial performance. And we are changing that, starting with patient stories, encouraging board members to do workarounds. And when you see the conditions, the actual concrete conditions that patients go through when they visit your hospital, I think it's easier to understand when we say that we need to engage patients in a different way. So bringing them closer to the reality and not just look at the numbers, for me has been a game changer. So that people see very, very clearly that it's good to have the patients there, you know, engaging with you. And where it's possible to even form specific patient advocacy groups that can then have their views being solicited and factored into the conversation, it's helpful. I think that the difficulty is that for a number of us, there's the fear that when we embrace the patients, it's just going to lead to our financial harm. And one colleague, I can't remember the name, said that his own experience shows right now on the chat that actually when you involve patients, it's to your benefit, because then you co-create and then they understand the real effort that you are putting in. And sometimes it's about sharing these stories, you know, of people that involve patients and then the benefits that, you know, they got from it. A lot of the time, there's just the fear of the unknown. What if it goes wrong? What if it goes wrong? And I think our role as managers is to slowly build that confidence, you know, so that we drive the system in a totally different direction.
Yeah. We have had a couple of comments about, you know, mining the information from patients and service users. And actually there was a really large scale survey done of patient experiences during COVID. So I'm happy to share that with people. It was done in America now in a group of private hospitals in the US. But it's astonishing the amount of information that they had from it. But I can share that with everybody if you want. And we have a couple more comments here as well. Yeah, from Katarina, and I think Aaron as well had also said that how mining the data from patients is very important. And Lewis has said, with reasonable investment into the health system to reap quality health services in the system, we need reasonable investment into the health system to reap quality health services in the system. How do one reconcile the need to improve QOC and the political will to maintain free for service healthcare? Yeah, how do we reconcile the need to improve it and the political will to maintain a free for service healthcare?
Well, so I think that raises issues around sustainability of the funding mechanism. And at the political level, often it's about the next election and the next vote. So what it takes, and that reminds me of Ghana, where one political party said that you are going to pay health insurance premium once in your lifetime. I think that those circumstances, we just have a responsibility to counter with technical arguments and to just show the unsustainability of some of these types of scenarios, and to also provide alternatives. So if this is not possible, what are some other ways in which we can generate funding to reduce costs becoming a barrier point of care, but at the same time, making sure that the whole system does not run aground. So I think it's a tension, but I think that the politics also gives us an opportunity, because if you look at the number of the interventions that have gone on in other places, it's all because of the desire on the part of politicians to address some concerns that come from people. And sometimes, you know, as health professionals, we think that we can be totally divorced from the political conversation, and the politicians would automatically adopt recommendations from our peer-reviewed articles. It just doesn't work that way. And so it's just a matter of constant engagement. And recently I was talking to a regional director in Ghana in the Upper West region, and he talked about the fact that they are doing what they call an integrated health plan. So essentially he works with the local government officials, regional ministers, and the two of them sign an MOU that shows what local government is going to do to support the health plan and what his responsibilities as a health manager are. And they tackle it, you know, together. And he described it as a pilot being tested and later on to be rolled out, because there's this long conversation about even decentralization that has not yet been actualized. So I would say that there's no straightforward answer. It's a matter of constant engagement.
Brilliant. Okay, thank you, everybody. Any questions, just email them to me and I'll forward them on. So thank you very much, everybody, for coming. Hopefully we'll see you next month, and we look forward to getting your reflections through. So thank you. Take care.